Wound complications following veno-arterial ECMO decannulation is associated with COVID-19 infection and ipsilateral dual cannulation by Dr. Aditya Safaya from University of Cincinnati.
Good afternoon, everybody, and thank you to the committee for the privilege of the podium and letting us present our work. VA or veno-arterial ECMO needs no introduction. It's been used for cardiopulmonary resuscitation. Whilst providing cardiopulmonary support, it also prevents end organ failure by providing tissue perfusion. Rapidly initiated can also be performed at bedside if really needed. Veno-arterial, veno-venous, and now VA ECMO is all being used, and we've been seeing that increasingly in the current pandemic of COVID. So it's important because recent studies have shown a 23-fold increase in the use of VA ECMO for cardiopulmonary resuscitation, and there's been a 35% decline in mortality. They use large bore venous and arterial cannulas, and it comes at a cost, and we are all aware of the dreadful vascular and wound-related complications. Now, vascular complications that require surgical intervention are independent risk factors for worse survival for these patients. Perfusion catheters, or reperfusion catheters, have definitely helped us mitigate some of the vascular complications related to perfusion. However, wound complications continue to remain the Achilles heel for these patients. Now, we looked at some of the femoral access site complications after ECMO decannulations, and we found that there was not a lot of data that could identify some modifiable risk factors. So our main aim was to identify modifiable risk factors to reduce wound complications after ECMO decannulation. We performed this at our institution. It was a retrospective single academic institution study. We examined patients that underwent surgical decannulation of their ECMO cannulas from the femoral site between 2014 and 2021. We defined wound complication as wound dehiscence or any wounds that were opened deliberately to promote healing by secondary intention. All our decannulations were standardized in the operating room with direct surgical repair of the femoral artery or the vein, which required either primary repair or patch repair whenever necessary. Analysis was done retrospectively in the usual fashion with multivariate and univariate analysis. We analyzed about 60 patients who underwent surgical ECMO decannulation, and the median number of days spent on the ECMO was about 4 days for these patients. Majority of them got a reperfusion cannula, and majority of them had it in the in the superficial femoral artery. The primary repair was performed in most of these patients, with only a few of them requiring patch repair, and 1/4 of the patients were identified as having wound complications, and they were treated with either local wound care or operative debridement. When we looked at the patient characteristics, we found age, estimated blood loss, days on the ECMO, and gender basically didn't have any association. However, we did find some association with BMI and wound complications. And when we looked at specifications regarding cannulations, it was interesting to see that patients who had arterial and venous cannula on the same groin had a statistically significant association with wound complications. Antegrade SFA cannulas, or the type of arterial repair, either primary or patch, did not have any association. That was statistically significant. Looking at patients' comorbidities, COVID-19 status came out as having a positive association. However, diabetes and previous groin surgery did not have any association. Looking at some of the variables closely, we found that actually same-side cannula and COVID-19 infection did have some statistical significant association. However, BMI did not come out to have that strong of an association. Now, where do we go forward with this small study? It's a single institution, small sample size, retrospective analysis, so we understand our limitations. Also, we understand VA ECMO is a procedure where time is of essence. So one doesn't have the luxury of deciding how you're going to put the cannulations. And sometimes these patients have vascular disease, and maybe the groin which they are cannulating is the only groin that has patent vessels. However, we recommend that if you at least consider an arterial and venous cannulation on the opposite side, we can help mitigate some of these modifiable risk factors, and we can probably help this patient. Because what's important is it's not just wound complication. It's not that the patients are being treated with prolonged ICU stays and cost, but these patients are also devoid of further treatment, such as maybe a transplant or LVAD if they have open chronic wounds. So, how can we work on this? And from an academic standpoint, randomizing a emergent procedure may be a problem, but I guess in future, if you collaborate and have a multi-institutional study with prospective analysis, we can probably come out with certain factors that can at least help with some guidelines. So in conclusion, in our study, wound complications after VA ECMO decannulation is associated with COVID-19 infection and arterial and venous cannulas placed on the same side of the groin. Thank you very much, and I open the chair to questions.
While we're waiting for somebody to come to the microphone, do you have any data on the length of time the patients were on ECMO prior to decannulation? Yeah,
there was median about 4 days, but we did not have any association with the length of time spent and wound complications.
Okay.
Okay. Yeah, I'm an Ahmed vascular surgeon in Marshfield, Wisconsin. That actually was my question about the length of the ECMO being in place and the wound infection.
Yeah, we didn't find anything really.
Hi, Ross Milner, Chicago. So, question for you: have you gone back to your cardiac surgery or cardiology colleagues and shown them this data, right? Because we're usually the ones who just have to clean up the mess, not the ones usually putting people on. So, obviously, if they can avoid same side, it seems to make a difference.
That's an excellent point, sir. So, in our institutions, vascular surgery is automatically involved for any ECMO for decannulation, and of course, to do such kind of a study and get IRB approval is going to be tough if you don't have a collaboration with your cardiac surgeon. So these kind of studies can actually help push our colleagues to better understand what, the point that we have been trying to say for a long time. So.
Yeah, Don Jacobs, University of Colorado. I am intrigued by the tibial access. I've not seen that. I guess maybe it should be intuitive. Maybe others have experience with it. But what are the circumstances and technique?
Yes, so a lot of the patients that would come in from outside hospitals where it's been a crash cannulation for ECMO, and if they are not comfortable placing a cannula in the SFA, a lot of the cardiologists at other hospitals may just place some kind of access in the posterior tibial most of the times, and they just connect the reperfusion cannula to that. So far, we had two patients, or I would say, two patients that had access in the posterior tibial artery, and we did not find any problems managing those patients afterwards.
Thank you. Quick question. I'm wondering if the same-site cannulation is kind of a reflection of a potential for a hematoma, because we know that groin hematomas are a risk factor for development of wound infection. So did you calculate or observe the number of hematoma rates after decannulation of the stem-site access?
Not exactly. We did not specifically look at hematoma. We did measure estimated blood loss during the operating time. Did not show much association. However, we did not specifically look at the hematoma size.
Dr. Bath?
Just a quick one, John Bath from Missouri. Great presentation. Two quick questions. Number one, I always thought about placing these percutaneously ahead of time and was always dissuaded by the supposed wound infection rate. So going forward is an idea that if, it's University of Cincinnati, you get called for all of these cases, maybe you'd consider placing proglides, let's say, for the duration of the ECMO cannulation, thereby obviating potentially an arterial stick. And then secondarily, on the contralateral sides, I used to, when I was there, just pull them out at the whole pressure, and so you don't have to cut down on that side. And so as CJ was saying, when you've got an arterial and venous stick, you have to repair both. So, I mean, obviously, I think there's a couple of quality things that you could certainly do, but would you consider placing proglides ahead of time and then putting the venous access on the other side?
Well, most of the times, again, these patients came already with the cannulas placed, so we really didn't have a chance. But that's a very good thought. We can definitely talk about this going forward.
Great work. Thank you.
Thank you very much.